Palliative care is still a relatively new specialty. And even in more established programs, there's good chances that you entering the palliative care or hospice workforce are entering a new program or a changing program or a growing program. So I think that forces you to think of yourself as you're not just going in to take care of patients, you're also going into a leadership role where you're going to be having to make decisions. And that's hard. And you don't get a lot of practice doing that until you just kind of have to do it. So my advice, I think, is what I've kind of adopted or learned or seen for in terms of making decisions. And this would apply probably in a lot of cases to patient care as well. In decision making, you should always think about how much time you have to make the decision. There's a tendency to feel like every decision needs to be made urgently, but you don't need to make hasty decisions if it's not necessary. Sometimes it's just enough to know what the options are and what the different considerations are, and sit on it for a while, and at a future time the correct choice will become evident. Or you might find that you didn't really need to make a choice at all because something else changed. So just be careful about making too many decisions, especially big decisions, too quickly. And I think this applies, definitely in your as you go into kind of more of a leadership position. Right. But good luck to both of you.
Thank you, Steve.
This is Sandy. Hi, you guys. It's been a great year. I just want to piggyback onto Steve, because I think what I would say about after doing this for a couple of decades now is just that it is a process, and that when we get the referral, the consult, there's always a question, and sometimes they don't know what it is. And some people are on one page, and some people are way down on that, like the last chapter of understanding all of this. So I think I've seen a lot of people on our team, and I think it's something that they have learned, is you don't have to go in on the first day and talk about every single thing. It really is a process, and trying to help the team, trying to help the patient and their families through that. They're all going to be at different parts of that process. So taking time, even though it might involve keeping the patient in the hospital a couple extra days or whatever, but just trying to make sure you do the right thing. That process piece is just so important to learn, and learn early, so that you don't have to feel like you have to fix everything, and try not to take on that pressure of trying to have to fix it right away. You guys are going to do great. It's been really good working with both of you.
Thank you, Sandy.
Sandy.
I'll go next. Just because I have pretty much been here the same amount of time you guys have been, maybe a few weeks longer, I have no idea. But so I'm in much of the same boat in learning, I think, than you guys are, and I've learned alongside you in many respects. But one of the things, and I'm sure you guys know this as well, but going into a room, and this kind of piggybacks on what Martin was saying, but when we have a consult and we do some review of the chart, and some of the preconceived notions that we garner, try and limit those. And I think I'm learning that. And I think because of my previous experience here in this particular hospital, I have maybe a few more about providers, about situations, about how I know people are going to act and that kind of thing. But I think I've been burned on my preconceived notions. So I think going in open, and with an open heart, and really truly listening to what everybody is saying. I think listening is the biggest gift that we can give to our patients and to ourselves, in trying to understand. And then, a little on the other side of this, maybe working on self-care during this process, because it can get heavy, it can get emotional, there's attachments, and just, knowing your resources for self-care, I think, is important too. So it's been fun getting to know you guys. Good luck to you. And I'm sure we'll keep in touch and keep hearing more about how things are going for both of you. So
Thanks, Mo.
Thanks, Maureen.
Hello, I'll piggyback kind of off Maureen too. I think not just like stuff from that you read from the chart, but I know sometimes I've been preparing to go into a room and you hear from another provider or the staff like, oh my gosh, this person is so whatever, so difficult, or and then I know, like, I don't think it doesn't change my approach. I mean, I still approach the patient the same, but I know for myself, I find sometimes I'm like, you have this like dread, or I'm thinking like, oh my God, this is going to be terrible, and like kind of stress myself out, and then do the meeting and it's fantastic. And it's like, well, I mean, maybe that, was somebody's opinion of someone. Maybe they caught them at a bad moment. Maybe personalities clashed or whatever. So like, yeah, try not to let what other people say. I mean, definitely take it into consideration, hear it, but don't let it impact you and, how you're feeling. Because I find that I've put extra stress on myself in those circumstances, and it's happened enough that I should know that I shouldn't do that, but I still do it sometimes, and you're like, oh man, this is gonna suck, and then it's great. So take care of yourselves. And it's been great working with you.
Thanks, Katrina.
Thanks, Katrina.
I would just say that, and I've stressed it multiple times, that palliative care is a team sport. So as physicians, we're almost, trained to instinctively be leaders. And we always feel that we have to be the one that's leading the team. But I think palliative care is slightly different in that everybody on the team has their own strengths, that we should, we should recognize who brings in what to the team. And there's moments where we really have to step back and let other people on the team sort of lead the process. And there may be many times where you are required, to provide your medical expertise and share your knowledge with the team, educate the team. But just remember that, this is a team sport, and pulling in all your resources and involving, that interdisciplinary aspect of care to these patients who have serious life-threatening illnesses, who have been dealing with chronic disease for a long time, really adds to the quality of care that we would provide. And making sure that you are using all the people in the team appropriately is going to be really, really helpful in your career, and also will make you a very valuable part of the team, that people will be looking at you to as the expertise, but also they'll know that they do rely on the other members of the team, and that they feel they're making everyone a part of the team. So using your resources, this is a team sport, and I really wish both of you the very best. And remember that this is your home base, so you can call us if you have questions about things. And we hope that you'll continue to be a part of the fellowship, and we can reach out to you to talk to some of the new fellows, or share your experiences. I think as the guinea pigs of our fellowship program, we've actually learned a lot from having both of you here. So wishing you the very best for a bright future.
Thank you.
Thank you.
Yeah. So I'll go next. Mine actually piggybacks off of that pretty well. Like Maureen, I came here from ICU, and I was really comfortable with my numbers and my protocols and my task list and the things that had to get done in a day. And coming to palliative care from that was a bit of a transition. I struggled with a little bit of the loss of the task list and the itemized kind of way of doing things, and more the broad approach. And we'll get there eventually. We've got a process, and we've got, but in ICU, you need insulin. We've got a sliding scale for that. You need ACLS. We've got a protocol for that. There's no protocol really for how to do palliative care. It's just the best approach for a family or for a patient, and it's up to you to kind of determine that. And I think making progress in the right direction in my career has come down to understanding that people consult us because we're on uncharted territory. There is no protocol for what we're doing often, and so they're looking to us for that critical thinking. It may not be critical thinking in the same respects as ICU, where what med do we turn to, or what dose, or what comes next, and the adrenaline rush that comes with that. But it's uncharted territory in a very different way, that they're looking to us for critical thinking on the bigger picture. So I think it's every bit as critical, every bit as important. It's just in a different realm, and they look to us for that experience, I guess.
Thank you.
Thanks, Lindsay.
Okay. So I guess two things. One, I just wanted to kind of expand on what Katrina said about, you get that feedback from the team that the daughter's crazy or the wife's nuts, or, the son is impossible. And sometimes that's true, but also I think more often than not, it's a reaction to how people approach those family members. And I think that if we just take a breath to sit down and approach with a non-judgmental, no agenda way, oftentimes that goes away. So I always try and I, like Katrina, kind of get a little stressed out when I hear that, like, oh great, gearing up for the worst. And I often find that that's not the case when you approach people with respect and kindness. Mm-hmm. And then the other piece of advice I've been given that really helps me is, that pressure that we get sometimes from outside of our team to get the code status, DNR, to make them not want the surgery, to make them not want the chemotherapy, whatever that may be. I don't know about the rest of you, but sometimes I let that get to me. And if you don't, God bless you. But when that does get to me, I just think to myself, the advice that I was given, that people have a right to accept what is offered. And if you're going to offer it, why wouldn't they consider that as a viable option? And so when you get that stress of they shouldn't want chemotherapy, but you're going to give it to them, so that's partly on us for offering it to them. It helps me get through the day of knowing, like, this is what the family wants or the patient wants, and not feeling that pressure. So it's been really great to get to know you guys, and I wish you all the best of luck, and I hope you keep in touch. Palliative is a small world, and I'm sure we'll see each other again.
Yeah, Patrice.
Yeah, thanks, Patrice.
I can go. As someone who's kind of made the transition from fellow to attending not too long ago, I would say keep being a lifelong learner. 1 year is short, and I've learned so much, and just from where I started to where I am now, and from the cases I've had to deal with. And I think when you're a fellow, sometimes you're shielded a little bit in the really difficult cases where the attendings might handle the politics and some things that you might just not see. And then all of a sudden you're the attending. And so don't hesitate to ask for help. Even if you think, I think I'm thinking about this the right way, but I just kind of want someone else's input too and see what they think. I know I've called Martin sometimes at 8 p.m. or something, just to get another set of ears on this and perspective and make sure I'm thinking about it right. So don't ever feel alone. Use your colleagues, whether it's palliative colleagues or non-palliative colleagues, other disciplines. If you have to, talk to risk management in the hospital, there's always people to help you, and you're not alone.
I think I can go next, Pooja. So, I can say the same thing, like me and Vani, we both started at the same time. So, first, 2 years have been something that, again, keep an eye open, keep on learning. You are going to learn each and every day something new, and, just continue to learn and listen to your nurses. I think, when we had our encounters together, I always told you, yeah, and I'll say it again, listen to your nurses, talk to them before encounter, talk to them after your encounter. You will see that you are getting a completely different perspective about the patient care. And again, we are here if you have any questions, anything that you want to run it off, please, we are here, just reach out to us. And yeah, it's been wonderful working with both of you this year, and we have learned a lot from both of you, so thank you.
Thank you, Pooja.
That's Pooja.
This is Brenda. I can.
Hey, Brenda.
Hi. So when I started with the group, I was with physicians, and a lot of the time it was our Ashok Choisani. And he taught me a really, really good way of approaching those situations where, you're seeing a very sick patient and all the family is gathered, and maybe somebody set up a meeting for you that you weren't even ready for. And, you don't know how they conveyed what palliative care is. And you walk into that room and everybody looks at you and they look scared. Like, oh no, here it comes. And in those situations, he always, and I try to do the same, I always lead with, tell me about this person. Tell me about your dad. What did they do? And I think that always sort of relaxes the whole room. It's like, oh, we're not here just to talk about failing organs. We're here to talk about this person. And I always found that so helpful for dealing with really scared family members. Excuse me. And just to add on, good luck to you guys, and it's been really great getting to know you, mostly remotely. I'll miss seeing your faces and hearing your voices.
Thank you, Brenda.
Brenda.
I've got something. This is Rachel.
Okay.
Hey, Patrick and Timu, you have brains in your head, you have feet in your shoes, you can steer yourself any direction you choose. You're on your own and you know what to do. You are the guy who will decide where to go. And then I'm going to skip to the end because otherwise this book is way too long. Will be your name Buxom or Bixby or Bray or Mordecai, Van Allen or Shay? You're off to great places. Today is your day. Your mountain is waiting. So get on your way.
Hey.
Nice.
Very nice.
Love Dr. Seuss.
Yeah.
A good doctor.
That was great.
That might be the perfect way to end it.